past chairman, Institutional Scientific and Ethics Review Board at St. Luke's Medical Center, Quezon City. He is also a past chairman and associate professor, Department of Medicine, St. Luke's College of Medicine, Quezon City. Also a past chairman, Department of Medicine, St. Luke's Medical Center, Quezon City. Without further ado, I would like to introduce Dr. Oscar Naides.
Good evening. I'm very grateful to the Philippine Society of Nephrology and in particular Russell Villanueva for inviting me to this webinar. And I'm also grateful to Patch for that very kind introduction. Okay. So I have nothing to disclose. Because the lecture involves relationships, I would like to describe to you or show to you two kinds of relationship which you are all familiar with. So if you are enjoying a breakfast consisting of a sunny side up fried egg and a savory, sweet, salty hamonado pork sausage and a cured, smoked, crispy bacon. What is your relationship, or what is the relationship of the chicken to your breakfast and the relationship of the pig to your breakfast? So the chicken was involved in your breakfast and the pig was committed to your breakfast. And so if there's a forceful analogy, we can probably state that an elevated serum uric acid or hyperuricemia is associated or is an independent risk for the development and progression of chronic kidney disease. So that probably would equate to a involvement. Whereas if there is a causality, meaning there is a cause and effect relationship, then there must be some commitment of the serum elevated uric acid into the development and progression of chronic kidney disease. And so this is my outline, and I will start my presentation by showing to you three population-based cohort studies. They are observational and epidemiological studies, which probably would give some basis for the elevated serum uric acid to be associated or be a significant or factor for the development of progression of chronic kidney disease. And this will be followed by some biological plausibility. It's a fancy term for pathogenesis, looking at a very recent concept on how uric acid can cause hypertension and chronic kidney disease. And then I will move on to share with you randomized controlled trials and systematic reviews and meta-analysis of these randomized controlled trials to probably show some causal cause and effect relationship between an elevated serum uric acid and the development and progression of kidney disease, chronic kidney disease. And I will end my presentation by showing to you the different or the recommendations from the different guidelines of different or guidelines by the different medical societies or organizations reference to the use of urate lowering therapies in asymptomatic hyperuricemia in preventing development and progression of chronic kidney disease. So it's the first of 3 cohort studies, and this cohort study addresses or will answer the question, does an elevated serum uric acid level increase the risk of incident kidney disease? And this is by the group of Weiner. The earlier population-based studies published in 2008. And it was based on 2 community-based cohorts totaling about 13,000 patients. Their mean baseline serum uric acid was about 6 milligrams per deciliter. Mean baseline serum creatinine was 0.9 milligrams per deciliter. And the mean baseline eGFR is 90 ml per minute. So there were 2 outcomes that were of interest: the incident kidney disease and death after they were followed up for about 8.5 years. So the outcome of incident kidney disease is based on eGFR and based on serum creatinine. And there is an incident kidney disease if the eGFR decreases by 15 ml per minute or greater, with the final eGFR less than 60 ml per minute. And if it is a serum-based creatinine, then the final creatinine should be 1.4 milligrams per deciliter. So the logistic regression analysis show that in patients whose baseline serum creatinine is 6.2, if it increases by 1 milligram per deciliter, the risk of developing incident kidney disease is increased by 7%, and the risk of dying is increased by 8%. And you have a similar pattern for the creatine-based serum creatinine, increasing the risk of incident kidney disease and death per 1 milligram per deciliter, increased from the baseline of 6.5 milligrams per deciliter. And so Weiner and the other authors concluded that an elevated serum uric acid level is an independent risk factor for incident kidney disease in the general population. The second cohort study is the Stanislas cohort study, published in the American Journal of Hypertension early this year. And it tried to answer the question, is hyperuricemia associated with hypertension and renal target organ damage? And this is based on a familial longitudinal cohort study from France, wherein healthy families and individuals totaling 1,006 families and 4,300 individuals. And they were followed up every 5 years. They underwent annual physical examination, blood pressure monitoring, and some laboratory examinations. About 916 parents and 570 children had serum uric acid levels determination and urine albumin creatinine ratios determined. So as I've said, they were followed up for 20 years. And the first visit and the fourth visit, I'm going to show you the fourth visit at 20 years. And the first outcome is hypertension, such that if there is an increase of the baseline serum creatinine of 70 micromole per liter or 1.2 milligrams per deciliter, the risk of developing hypertension is 32% and 28%. On the 20th year, for parents and children, the risk is about 33% higher and 12% higher. If you look at the development of microalbuminuria, it's significant after 20 years, meaning about the risk of developing microalbuminuria is 81% higher if the serum creatinine increases by 1.2 milligrams per deciliter. The association of a high baseline serum uric acid and a low GFR and a higher AIDS is shown on baseline, wherein at 41 years it is significant, and at this time the eGFR is reduced to 1.2 ml per minute if the baseline uric acid is about 1.2 milligrams per deciliter. And as you grow older, there is more reduction of the eGFR. And so the authors concluded that the increase in the serum uric acid is associated in the development of hypertension, vascular and renal target organ damage in initially healthy midlife subjects. This is the third cohort study. It is the known CKD study, or the Korean cohort study for outcomes in patients with kidney disease. And the cohort included 2,400 or 2,042 patients from 9 centers in Korea. Their mean age is 54 years. They were in stage 1 to 5 ND, and their mean uric acid is about 7 milligrams per deciliter. So their baseline uric acid is divided into quartiles. First quartile will be, which will be the reference, has a baseline uric acid of 4.7. Second quartile is 6.4. Third quartile is 7.6, and fourth quartile is 9.5. So that on the outcome of the renal composite, which includes initiation of dialysis, a twice increase in the baseline creatinine, and kidney transplantation, the risk of developing the composite renal outcome is higher at 28% when the serum uric acid increases by 1 milligram per deciliter from baseline. And the higher the uric acid, baseline serum uric acid, the higher is the risk, from an increase of 71% to about 200% into about 350% or 360%. I cannot see the dialysis data, but they did a subgroup analysis in patients who receive allopurinol or not, and look at survival probability. So there is no difference in the survival in patients who took allopurinol or those who did not take allopurinol. Likewise, those patients who took febusoxstat or those who did not, there was no significant difference in the survival. And so the authors concluded that hyperuricemia appears to be an independent risk factor for composite renal outcome, like initiation of dialysis and transplantation during the follow-up period of 2 years. However, allopurinol and febusoxstat did not show renoprotective effect. Okay. What I'm going to show to you is a new concept of the pathogenesis or the effects of uric acid in terms of developing hypertension and chronic kidney disease. This is data from Claudio Ponticelli of the idiopathic membranous nephropathy fame. And his group made or published a very good narrative review, and was published last week in the Kidney International. And there is a two-hit model. The first hit model is a non-immunologic effect, and the second is an immunologic effect of uric acid. So let me start with the first hit. So in the kidneys, uric acid activates or upregulates renin, angiotensin, aldosterone activity, and by doing so, it increases sodium reabsorption. It expands or increases the extracellular fluid volume. At the same time, hyperuricemia causes sympathetic overactivity. And therefore, sympathetic overactivity in concert with the increased activity of the RAAS will cause a, modest but consistent elevation of blood pressure causing a systemic hypertension. In the arteriolar compartment of the kidney, uric acid also enhance the activity of the NADPH-mediated oxidative stress, and it decreases the activity of nitrate oxide synthase and increase the production of thromboxane. And all of this will cause proliferation of vascular smooth muscle cell, endothelial dysfunction, and cause arteriolar changes, which is widespread or extensive, causing glomerular hypertension, hypoxia, and fibrosis. The hypoxia that develops will cause a severe or aggravate the direct effects of uric acid into the renal tubules, and it increases oxidative stress and enhance epithelial mesenchymal transition, again causing fibrosis, particularly in the tubulointerstitial area, causing eventually chronic kidney disease. This is the second hit of the two-hit model, and this focuses the immunologic effects of uric acid. Uric acid, either in the soluble or in the crystalline form, interacts with the immature dendritic cells and the resting macrophages in different areas, wherein this internalized uric acid will interact with NOD or NAD LR or receptor, toll-like receptor or node-like receptors. And through this interaction, there is activation of resting T cells, and there is activation or triggering of the inflammasomes and inducing the expression of inflammatory cytokines. Uric acid likewise interacts with toll-like receptors. They have a downstream signaling causing, again, activation of resting T cells and triggering inflammation and inducing the secretion of pro-inflammatory cytokines. Both the NAD like receptor and the toll-like receptor both causes maturation of the immature dendritic cells and activation of the resting macrophages. The mature dendritic cell now migrates into the lymphoid organs, where the mature dendritic cell with interact with CD8 and CD4, causing polarization and causing fibrosis and vascular remodeling. Whereas the macrophage pro-inflammatory proliferation causes fibrosis and vascular damage. In the polarized CD4 and CD8, you see increased sodium reabsorption and vascular resistance, and this will lead to hypertension and probably, again, explaining in the immunologic effects of uric acid in the causation of hypertension and chronic kidney disease. So I refer this to you. This is a good narrative review, and it is very recent. The publication is July 7, 2020. Now I'm moving on to show to you several systematic reviews and some randomized controlled trials that probably will be a basis for a causality in the relationship of elevated serum uric acid and the development and progression of chronic kidney disease. So this is the first meta-analysis that tried to answer. This is by Samson. It is published in the Cochrane Database of Systematic Reviews in 2017. It tried to answer the question, does uric acid lowering therapies prevent or delay progression of chronic kidney disease? So they searched Cochrane, M-based Medline, and Hansert's clinical trials up to July 2017. They identified 12 randomized controlled trials totaling 1,187 patients. They included randomized controlled trials that enrolled patients who had normal kidney function and those with chronic kidney disease, and they compared uric acid lowering therapies versus placebo. So that at 1 year, there were 4 studies involving 253 patients. There is a high quality of evidence. There is a reduction of, or the uric acid was reduced to about 3 milligrams per deciliter or lower compared to in patients who received uric acid lowering therapy compared to placebo. And at 1 year, there seems to be a better kidney function in the patients who took a uric acid lowering agent. The serum creatinine was lower by about 0.8 milligrams per deciliter in the uric acid lowering group versus placebo. But it was not sustained. The eGFR, there was no difference between the uric acid lowering groups and placebo. Their confidence interval studied the null value of 1. Likewise, the outcome of dialysis at 2 years is not significant. The confidence interval, again, straddling the line of unity. Cardiovascular events, likewise, is not significant. Also, death at 6 months and 2 years, there was no significant difference between lowering and placebo. And thus, the reviewers concluded there is limited data which suggests uric acid lowering therapy may prevent progression of chronic kidney disease, but the conclusion is very uncertain. And benefits were not observed at all time points, and the study quality was generally low. And this is the second meta-analysis published by the group of Chu Chen Lin in 2019. And it tried to answer the question, does febusoxstat versus placebo or other uric acid lowering therapies lower risk of progression among patients with chronic kidney disease and hyperuricemia? So this is a meta-analysis involving about 11 randomized controlled trials with 1,300 participants. They compared febusoxstat versus other urate lowering therapies or placebo. The outcomes at at the range of 2 to 12 months, the uric acid was significantly reduced in the febusoxstat group versus the ULT group plus placebo. Likewise, there was a significant improvement of the EGFR in patients with stages 3 and 4. And likewise, there was a lower systolic blood pressure and diastolic pressure in the febusoxstat group compared to the other ULT and placebo group. And therefore, the reviewers concluded that febusoxstat presented a renoprotective effect on CKD patients stage 3 and 4. However, more studies with a larger sample size and higher quality are required to clarify the role of febusoxstat use in the progression of chronic kidney disease. So after the publication of that meta-analysis, the FREED study done by the group of Kojima was published in the European Heart Journal in 2019. And this meta-analysis this randomized controlled trial tried to answer the question, does febusoxstat compared with conventional therapy with lifestyle modification reduce the risk of cerebral, cardiovascular, and renal events in patients with hyperuricemia? So they involved adult patients in enrolling in 141 centers whose serum uric acid is between more than 7 and 9 or less than milligrams per deciliter. They are at high risk for cerebral and cardiovascular disease or renal disease. Their mean age is 76. About 69% are males. About 94% have hypertension. Their mean systolic blood pressure is 133/74. About 66% of them have existing renal disease, and their baseline EGFR is 55 mmol per minute, and their albumin creatinine ratio is 18 milligrams, and about 8% has cerebral disease, and 18% has 18%, and their mean uric acid is 7.5 milligrams per deciliter. So definitely these patients are at high risk for developing cerebral, cardiovascular, or renal disease. So they were followed up for 36 months. This is a prospective, randomized, open but blinded endpoint. There was allocation concealment and there was intention to treat. 537 were randomized to febusoxstat at 10 to 40 milligrams per day, and about 533 patients were randomized to receive allopurinol 100 milligrams per day. So there was a significant lowering of the uric acid, which was more in the uric acid group, in the febusoxstat group, compared to the non-febusoxstat group, which was significant. But if you look at the primary composite outcome, there was a 25% reduction of the risk of developing primary outcome in the patients who took febusoxstat compared to the patients who took placebo. And if you look at the renal outcome, renal impairment outcome, which included development of microalbuminuria, overt proteinuria, doubling of serum creatinine, or progression of CKD. Again, there is a significant reduction of the risk of developing renal impairment among the patients who receive febusoxstat compared to those who receive non-febusoxstat. Thus, the author concluded that febusoxstat lowers uric acid and delays the progression of renal dysfunction. So after the publication of the FREED study, the group of Chu Charat, so if you were able to join the first presentation, the author Chu Charat was also mentioned, being the lead reviewer of a meta-analysis on a low-protein diet, which was also a very recent 2020 review article. So this review article or meta-analysis tried to answer the question, what are the effects of febusoxstat versus placebo on kidney function of patients with hyperuricemia? So they searched PubMed, Embase, Cochrane Central Register of Concurrent Trials, publications from 1980 to January 2019, they were able to identify 9 randomized controlled trials, 3 trials from the US, 3 trials from Japan, 2 from Korea, and 1 from Malaysia. So the randomized controlled trials involved patients who had asymptomatic hyperuricemia with or without chronic kidney disease, and they compared placebo versus or febusoxstat versus placebo. So there was a significant reduction in the serum uric acid in the febusoxstat group with a weighted mean difference of 206 uh, uh, micromole per liter, or this is roughly about 3 milligrams per deciliter. The serum creatinine also was lower with a mean difference of 3.5 macromole. It's significant, but probably not clinically important. The EGFR at 6 months at the end of the study uh, for all patients was also higher in the patients who had received febusoxstat with a 2.86 and 2.69 point estimate of the weighted mean difference. And when they did a sensitivity analysis looking at or involving only patients with CKD, again, it was the GFR was higher in the patients who received febusoxstat compared to placebo. Likewise, the systolic and diastolic blood pressure, there was a lower systolic and diastolic blood pressure in the patients who were randomized to receive febusoxstat versus placebo. The other outcomes like albuminuria, cardiovascular events, joint symptoms, diarrhea, stroke, and arrhythmia did not reach statistical significance. And therefore, the group of Chuacharat and reviewers concluded that treating hyperuricemia with febusoxstat may slow progression of CKD, irrespective of baseline renal function, without significantly associated increased risk of major cardiovascular events, diarrhea, joint symptoms, arrhythmia, stroke, compared to placebo. Okay, before I leave febusoxstat, in 2018, the publication of the CARES study led to some uncertainty on the safety of febusoxstat in terms of major cardiovascular events, cardiovascular death, and cardiovascular mortality. So I'll just skip some of these slides and we'll just focus to you that the risk of cardiovascular death is higher by 34% in the patients who were randomized to receive febusoxstat compared to allopurinol. And you have a similar data for all-cause mortality. There is a higher risk of death. Death is 34% risk or the percent higher in the patients who receive febusoxstat compared to those who receive allopurinol. And thus, the author concluded that in patients with gout and major cardiovascular coexisting condition, febusoxstat was non-inferior to allopurinol with respect to rates of adverse cardiovascular events, but all-cause mortality and cardiovascular mortality were higher with febusoxstat and with allopurinol. With this randomized controlled trial published in 2018. The following year, the group of Cheng Wei Liu did a systematic review and meta-analysis trying to answer what are the comparative effects of febusoxstat versus allopurinol in patients with hyperuricemia or gout in all-cause mortality, cardiovascular, and skin adverse reaction. So they included 13 randomized controlled trials totaling 13,500 participants, randomized controlled trials that involved patients with hyperuricemia or gout, and they compared febusoxstat versus placebo. And so for all-cause mortality, it did not reach statistical difference. The odds ratio is 1.29. However, the lower bound of the confidence interval is 1. Likewise, cardiovascular death, the lower bound of the confidence, 95% confidence interval is 1. But skin adverse reaction was lower, and the risk of developing adverse skin reaction is 65% lower in the patients who took febusoxstat compared to the adverse reaction. So the reviewers concluded that febusoxstat versus allopurinol was associated with improved safety outcome and comparable mortality and net clinical outcome in patients with hyperuricemia. Okay, so before I leave febusoxstat, very recently in June 22, 2020, there were 2 randomized controlled trials that were published in the New England Journal of Medicine. The CKD fix study and the PEARL study. The CKD fix study is done by the group in George Institute. If you remember, 2 Wednesdays ago, the webinar speaker was Vlado Perkovic. Vlado Perkovic is from George Institute, and she was also a part of the CKD fix study. So the CKD fix study tried to answer the question, does allopurinol delay progression of chronic kidney disease? And this is a multi-center, multinational randomized controlled trial involving patients from New Zealand and Australia. They included adult patients who are stage 3 or 4, and they are high risk for progression. Their UACR is 265 milligrams per gram or more, or their EGFR was reduced by 3 to 5 ml per minute during the preceding year. So they are rapid progressors. They do not have a history of gout. Their mean age is 64 years old. 63% were females, about 45% had diabetic kidney disease. Their mean EGFR is 31 ml per minute, so severe kidney disease, and their mean urine albumin creatinine ratio is 716 milligrams per gram, and their baseline serum uric acid is 8 milligrams per deciliter. About 76% were on RAS inhibitors. 369 patients were included out of the planned 620. There was very slow enrollment of this of patients, and thus they have to close the enrollment and make do with 369 patients. So there was a 104-week follow-up. 185 were randomized to receive allopurinol. 30% of them eventually discontinued. About 184 were randomized to placebo. About 25% of them eventually discontinued. When you look at the serum uric acid at follow-up, at the end of follow-up, there was a lower uric acid from baseline, 8 to 5.1 milligrams per deciliter, versus in the allopurinol group, versus 8 to 8.2 milligrams in the placebo group. There was a significant lower uric acid of about 2.7 milligrams per deciliter in favor of the allopurinol group. However, if you look at EGFR, adverse event, death, and end-stage kidney disease, there was no significant difference between the allopurinol group and the placebo group, leading the investigators to conclude that in patients with CKD and a high risk of progression, urate lowering therapy with allopurinol did not slow the decline of EGFR as compared to placebo. In this same issue of the journal, again, June 22, 2020, the PEARL study was published. Thus, and tried to answer the question, does lowering of serum urate level with allopurinol slow the decline in eGFR in type 1 diabetes? And this is a multi-center involving 16 sites, type 1 diabetes with an eGFR between 40 to 99 ml per minute. They have early to moderate diabetic kidney disease. Their urinary albumin excretion rate is between 20 to 3,333 microgram per minute, or the decline in eGFR is at least 3 ml per minute for the previous 3 to 5 years. And their serum uric acid should be at least 4.5 milligrams per deciliter. So they were able to enroll 530 patients, whose mean age is about 51 years, about 64% were males. The duration of diabetes is 35 years. The baseline GFR measured by the iohexol method is 68 ml per minute. The urinary albumin excretion rate is about 42 microgram per minute. The baseline serum uric acid is 6.1 milligrams per deciliter, and a fairly controlled blood sugar of HbA1c of 8.2%. They were given allopurinol 267, and 263 were randomized to placebo. They were followed up for 3 years. And if you look at the mean difference in the decrease of mean eGFR from baseline at the end of 3 years, doubling of serum creatinine or ESKD, there was no significant difference between the group who received allopurinol and those who received placebo. And thus the authors concluded that we found no evidence of clinically meaningful benefits of kidney outcomes among patients with type 1 diabetes and early to moderate diabetic kidney disease. Okay, so this is not the last part of my presentation. Reviewing with you the recommendations from different medical societies or organizations. And this is from the KDIGO 2012 Clinical Practice Guideline. This is a dated guideline and this must be updated. But they have stated that there is insufficient evidence to support or refute the use of lower serum uric acid concentrations in people with CKD with either symptomatic or asymptomatic hyperuricemia in order to delay progression of CKD, and this is not graded. The KDOKI likewise gave a commentary on this 2012 KDIGO clinical practice guideline, and they said that they agreed with the ungraded statement that there is insufficient evidence for the recommendations for use of uric acid lowering agents for the prevention of CKD progression. The group of Richard Johnson reported a statement from the scientific workshop organized by National Kidney Foundation on the topic of hyperuricemia, acute and chronic kidney disease, hypertension, and cardiovascular disease. And this is a 2018 publication. And they have stated that although several clinical trials suggest benefits of urate-lowering therapies on kidney function and insulin resistance, others have been negative and many trials have limitations and insufficient power. Thus, whether uric acid has a causal role in kidney and CVD requires further study. We reviewed up to date, and their literature review is very current, June 2020, and their last topic updated was June 29, 2020. And their recommendation also is that we consider pharmacologic lowering therapy with xanthine oxidase inhibitors or uricosuric agents as generally unwarranted for upper normal range serum acetate urate values or for asymptomatic hyperuricemia. And for those who are worried that patients who have asymptomatic hyperuricemia develop gout, this is a very recent ACR guideline 2020 on the management of gout. And this is the recommendation for patients with asymptomatic hyperuricemia, their serum uric acid is more than 6.8 milligrams per deciliter, with no prior gout flares or subcutaneous tophi, we conditionally recommend against initiating any pharmacologic urate-lowering therapy such as allopurinol, febusoxstat, probenecid over initiation of pharmacologic uh, urate-lowering therapy. So it looks like majority or almost all of the medical societies to medical organizations do not recommend the use of a urate-lowering therapy for patients with asymptomatic hyperuricemia for the prevention of the development of and progression of CKD or the development of gout. And so, in conclusion, I have stated to you and have I gave you data based on population-based cohort studies that there is an association between an elevated serum uric acid in the development of progression of CKD and asymptomatic hyperuricemia is an independent risk factor for the development and progression of CKD. I have shared with you a recent model to explain the causes or the uric acid association causing hypertension and chronic kidney disease, both on a non-immunologic HIT model and an immunologic HIT model. I have shared with you systematic reviews and meta-analysis and randomized controlled trials that may probably give credence to a causality or a causal cause and effect relationship between an elevated serum uric acid and the development of progression of kidney disease, particularly the systematic review on the use of febusoxstat, the latest meta-analysis. And I showed to you the recommendations of the different medical organizations and societies wherein they were uniform in their recommendations not to recommend the use of urate-lowering therapy in patients with asymptomatic hyperuricemia in order to prevent the development and progression of kidney disease. And so what's my take? The cause and effect relationship between hyperuricemia and in the development of progression of chronic kidney disease is becoming more evident. Urate-lowering therapy, particularly febusoxstat, may prevent the development and progression of CKD, but there is not enough or sufficient compelling evidence to recommend the routine use of urate-lowering therapies as part of standard of care in patients with asymptomatic hyperuricemia to prevent the development and progression of CKD. And we need adequately powered randomized controlled trials with adequate inclusion criteria, patients with early stages of CKD, patients who are younger. And they should include the outcomes of end-stage kidney disease, dialysis, or kidney transplantation as individual outcomes and not only as a part of a composite outcome. So while waiting for these randomized controlled trials to get started and to get published and finished, what can we do? Okay. So again, the decision to give or not to give urate-lowering therapies among patients with asymptomatic hyperuricemia depends on the patient's preferences and value judgment after you give that patient an informed choice. And the decision is better shared between you, the nephrologist, and the patient. Before I end, I would like to thank Doctors Carlo Buado, Blesa Pelayo, Liboyd Valencia, Joanna Santos, Bernadette Magsalin, Jusine Toledano for retrieving, critically appraising, and making the visual abstracts of my presentation. Thank you for your attention, and I'll be very happy to take your questions. Maraming salamat po.
Thank you very much, Dr. Naidas, for that very informative and up-to-date discussion on the relationship of serum uric acid and progression of in the development and progression of CKD. So just a reminder to type your question into the question box in your control panel. So going back to our case. Okay. So majority, 70% answered yes, while 22% answered no, and 8% not sure. So we will go ahead and take some time for questions now. Are you okay, na, sir?
Yes.
Okay, sir.
So I'm not surprised about the 70% of the participant or 75% of the participant answering yes. Before I prepared for this lecture and reviewed the articles, I also tend to incline to use urate lowering therapies in patients with asymptomatic hyperuricemia.
So it looks like we already have a lot of questions, Dr. Naidas.
Yeah.
For the first question, is there a particular reason why febuxostat seems to work in renoprotection while allopurinol didn't? Does the renoprotection go beyond uric acid lowering effect alone?
Okay. First, there is a comparison in the effectiveness of febuxostat versus allopurinol in terms of lowering serum uric acid. And the studies have shown that febuxostat is more effective in lowering serum uric acid compared to allopurinol. But in the CKD fix and the PEARL study, there was also reduction of the uric acid, serum uric acid, but this did not translate to improvement of outcomes in terms of eGFR and the other outcomes. And this, the theory that there might be some mechanisms other than lowering of serum uric acid, and thus you go now into the immunologic mechanisms and non-immunologic mechanisms of the models I had mentioned earlier, that the uric acid, particularly, reduces oxidative stress. It reduces tubular interstitial inflammation and fibrosis, and likewise it reduces the renal ischemia perfusion injury. I'm not really sure if that is also happening in allopurinol, but in my readings, it is consistent that these mechanisms are operative in febuxostat in terms of having some clinical improvement outside of the urate lowering capacity of febuxostat. Yes, I think there is some mechanism to explain the benefit of febuxostat other than just reducing serum uric acid. Your speaker is not working. Please check your connection.
Okay. So for the next question, sorry.
Let me see. Okay. So you did not get my answer to the question. The answer is yes. It's not only the lowering of the serum uric acid, but there are also other mechanisms like reduction in the inflammation and fibrosis of the tubular interstitial space for febuxostat, the reduction of oxidative stress, and the reduction of the renal ischemia. Again, my okay. Okay. Patch, can you hear me now?
Yes, sir.
Yeah.
Opo.
Can I take the
Yes,
next
sir,
question?
doctor. Yes, sir, doctor. Yes, sir. Opo. For the next question, um, how does uric acid activate the renal angiotensin aldosterone system?
Okay. Um, I, I refer you to the very good narrative review by the group of Claudio Ponticelli. It's published in the Kidney International, July 7, 2020. I read somewhere that it has some mechanism on the activation of the RAS by the uric acid. But on top of my head, I cannot give you the answer.
Okay, thank you, doctor. For the next question, at what level of hyperuricemia do you prefer to start hypouricemic agents?
Uh, it's variable. Generally, it's above 7, but the ACR guideline has a lower floor. It's about 6.8 milligrams per deciliter. But as I've said, because of the data that I have shown you, I'm inclined not to give a urate lowering therapy in patients with asymptomatic hyperuricemia, unless it becomes persistent. It's above 10 or 11, and if you measure their urinary uric acid, it's about more than 1,100 milligrams. And for this reason, you must have to give a urate lowering therapy. You have to hydrate this patient, and you have also to give a drug that would enhance uric acid excretion.
Excretion.
Wala
Thank
na
you
naman
very
ako.
much. For the next question, it was shown that there is association of hyperuricemia and CKD. Why do you think that lowering of urate levels does not show any benefit?
It's just a matter of uh, you know inadequate follow-up. Maybe one there are some limitations in the methodology of the trials that did not show some benefits, and this can be due to the study being underpowered, not enough patients. Like in the CKD fixed study, they were only able to enroll 60% of the actual number of can you hear me? Because
Yes, sir. Yes, sir.
somebody has said that your speaker is not working. Please check your
Yes,
connection.
we can hear you, sir.
Okay. So the CKD fixed trial, only about 60% of the patients that have to be enrolled for an adequate power studies were really enrolled. They have to stop the recruitment because there was a very slow enrollment. And it is for this reason probably that many physicians uh, do not have the equipoise, meaning they do not have that uncertainty. And like most of you, we will give a urate lowering therapy in patients with asymptomatic hyperuricemia. So that may be one reason why there is a slow rate of enrollment, because many physicians would not enroll these patients because they themselves will give already or start urate lowering therapy.
Okay, thank you, Dr. Naidas. Next question. If the uric acid is already normal, do we have to discontinue it? At what level should it be maintained?
Okay, like the statin trials, if we achieve our goals for the LDL and total cholesterol, we do not stop the statin. So the studies were about 2.5, 3 years at most, but we don't have data that if stopping at 3 years, would it lead to a decrease in the effectiveness of the prevention of progression of chronic kidney disease? That we do not know. But if you can extrapolate data from the statin trials, then we should not discontinue urate lowering therapy if you achieve the goal of a uric acid less than 7 or less than 6.8 milligrams per deciliter.
Okay.
Yeah.
Okay, thank you, sir. Next question, what are the characteristics of patients that should be given uric lowering agents?
Okay. The CKD fix and the Pearl study recruited or enrolled patients who had very severe chronic kidney disease, stage 3 and 4. And I have said in my last slide that large randomized controlled trials who are adequately powered should enroll patients who are younger, and they should have better kidney function. If you go back to the 2-hit model for the effects of uric acid in terms of hypertension and CKD, you see that early on there is already inflammation going on, there is already fibrosis, and they should be addressed early on for it to be effective. That's my take.
Thank you, Dr. Naidas. For the next question, would you still use urate lowering therapy to manage known pathophysiology of hypertension and in turn decrease the progression of CKD?
As I've said, having reviewed the data I've shown you, my inclination now is not to use or initiate urate lowering therapy among patients with asymptomatic hyperuricemia. I failed to mention in our discussion that particularly in patients with diabetes and hypertension, the use of SGLT2 inhibitors are effective in terms of improving blood sugar, improving blood glucose, blood sugar, blood pressure, and likewise improve serum uric acid because there are transporters in the of uric acid like ABCD G2 in the proximal tubule that will enhance the secretion of uric acid into the tubules, and thus it lowers uric acid.
Okay, thank you. Next question, would you still use, what is your threshold for in starting urate lowering agent in asymptomatic CKD patients? So I think we already answered that question.
Yes.
Is there a guideline-based target for uric acid lowering? How significant is diet in urate lowering?
Okay, let me answer first the diet. Okay, if you remember the patient that we discussed earlier, the patient was given a trial of a low purine diet for 4 months, and despite that, the serum uric acid from 7.5 it went up to 8 milligrams per deciliter. And so, just like the lipid guidelines, the hypertension guidelines, patients with asymptomatic hyperuricemia, I think they deserve that they should be prescribed a low urine diet, recognizing also that if you give them the list of a low purine diet, and once they go over it, ang unang sasabihin sa iyo, Dok, baka wala na kumakain. Okay? And so, if the problem really is a small portion of patients would agree to a low protein diet, and those who agree would probably fail to be consistent to be on a low protein diet. And this is because you cannot, it's difficult to deny a person something that is pleasurable. So how can you deny a person to have a sweet tasty tocino, pork tocino for breakfast, pork sausage for breakfast, and bacon for breakfast. So it's something that is pleasurable, and you have issues really of compliance. But having said that, I still would attempt to give a low protein, a low purine diet. The first question was Patch.
The second question, sir, is how significant is diet in
Yeah, I
urate
answered that
lowering?
already. The first part of the question.
Sorry, is there a guideline-based target for uric acid lowering?
Okay, so if you use the ACR guideline, College of Rheumatology, in the treatment of asymptomatic hyperuricemia, and the outcome is to prevent gout, the threshold is about 6.8 or lower. So that's the target that you would like to have.
Okay, sir. For the next question, do you have any data on probenecid?
One of the systematic reviews that compared urate lowering therapies versus placebo, the first meta-analysis by published in the Cochrane database, probenecid was included in the group of urate lowering therapies, but they did not perform a sensitivity analysis looking only at allopurinol, looking only at probenecid, and looking only at febusoxstat, because there is not enough patients, or it is underpowered to really see the effect of each particular urate lowering therapy, febusoxstat, allopurinol, and probenecid. But offhand, I wasn't able to see. I think there are, but we did not review this. I think there are trials on probenecid in terms of lowering urate therapies, serum uric acid.
Thank you very much, sir. For the next, I think the reason why we have revisited this question is because we have a better drug to lower uric acid, which has less side effects, just like an acetylcysteine, which is being given almost routinely despite lesser evidence for conscious nephropathy. While awaiting the proper RCT, since it's a very easy drug to use compared to allopurinol, reducing CKD progression might be a very compelling reason, more so since we know that uric acid is one of the earliest substances that is failed to be excreted.
Yeah, I agree. But I have to go back to the CARES trial and even the subsequent meta-analysis looking at the cardiovascular safety in terms of cardiovascular and all-cause mortality. It's barely touching the odds ratio. So you cannot still exclude a no difference and a higher risk of death. When I say compelling reason, it's similar to the lipid guidelines for primary and secondary prevention. You have large data that's numerous large randomized control trials that would support the recommendation that statin prevents cardiovascular events, all-cause cardiovascular mortality, and all-cause mortality in primary and secondary prevention. Like standard of care of the use of ACE and ARB in diabetic kidney disease, there are numerous randomized control trials that would now be the basis for these recommendations. What I would like to see, as I've said, is to have more randomized control trials that are robust, adequately powered, enrolling different subgroup of patients, similar to the lipid trials, to diabetic kidney trials. That in that case, if you get results and there are positive results, then that would be basis for us to give a very strong recommendation to use urate lowering therapies among patients with asymptomatic hyperuricemia to prevent the development of and progression of chronic kidney disease. But
Okay.
as I've said in the last my take, again, the decision to take or not to take still would be based on patient preferences, value judgment. After you give them the informed choice, you give them the information, what's the benefit, what's the harm, what's the weight of the evidence, and it's better that you will share with the responsibility of making that decision with the patient.
Thank you very much. Last three questions, sir. When do you decide to discontinue or decrease the dose of urate lowering agents with CKD who have been proven to have persistent hyperuricemia?
As I've said, just like in the lipid trials, if the LDL cholesterol is at low, you do not stop the statin therapy. So more so if they persist to be hyperuricemic, then you maintain them. But at the same time, you have to investigate other causes of hyperuricemia, like there might be some secondary causes of hyperuricemia. And that is very important that you go through the list, differential diagnosis, and investigate what each one of them based on clinical grounds and based on laboratory examinations.
Okay, for the next question, sir. The link between the RAS and uric acid, which was discussed by Ponticelli, explained the uric acid lowering effect by losartan, and why is this only seen in losartan but not with other ARBs?
I do not know the answer to this question.
Okay, next, we'll proceed, sir, with the next question. Most cardiologists would discontinue febuxostat and shift to allopurinol. With the evidence you presented, what are your thoughts, sir? Assuming there is indication to maintain on urate lowering agent.
Yes. The CARES study was published in 2018, was really something that is practice changing, particularly among cardiologists, because that was a very valid randomized controlled trial that showed a higher risk of cardiovascular death and all-cause mortality among patients who receive febuxostat compared to placebo and allopurinol, I mean, and that gave them the impression that it's really harmful compared to allopurinol. But if the recent meta-analysis subsequent to the publication of the CARES study, the 2019 meta-analysis, looking at the safety of comparing the safety of febuxostat and allopurinol, the risk of cardiovascular death and all-cause mortality is almost not significant. So maybe they would like to look at this meta-analysis and probably again would change their practice of considering again febuxostat as a treatment for asymptomatic hyperuricemia in the light of this meta-analysis, which included the CARES study.
Okay, thank you, sir. For the last question, for our last question, for patients with CKD secondary to chronic tubulointerstitial nephritis due to urolithiasis, are there studies that showed benefit for those given febuxostat for patients whom allopurinol cannot be given?
I specifically did not discuss uric acid kidney stones. Excuse me. But it's one of the indications to give urate-lowering therapies in patients with hyperuricemia and they have kidney stones. So you have to give. Considering that febuxostat is more effective in lowering serum uric acid compared to allopurinol, you may consider allopurinol. But recognizing also that there is some uncertainty on the cardiovascular safety of febuxostat over allopurinol. Likewise, you must also consider that the safety of scarce severe cutaneous adverse reaction is great. Steven Johnson's is greater among patients who receive allopurinol compared to ribosoxal. So those are the things that you consider when you choose which one, which urate lowering therapy would you use, ribosoxal or allopurinol.
Okay, thank you, sir. Looks like we answered all your questions. Sir, is there anything else you would like to mention?
As I've said, I initially when I was preparing for this lecture, when you asked me that same question in the clinical scenario, my answer would be yes. But after reviewing the data, I have now uncertainties on whether I'm going to start urate lowering therapy in patients with asymptomatic hyperuricemia in order to prevent development and progression of kidney disease. However, as I've said, because of some data, though it's not enough to be compelling data, this I will have to discuss with the patient, and the patient would decide based on his value judgment, preference, and after I have given all this information of the benefits and risks of urate lowering therapy in the setting of asymptomatic hyperuricemia.
Okay, thank you very much, sir. Okay. So I think we answered all our questions. Thank you very much, Dr. Naidas, for that very informative discussion.
My pleasure.
Thank you, sir. On behalf of the Philippine Society of Nephrology, we really appreciate you taking time off your busy schedule to join us on our weekly webinar series. Again, I would like to thank our sponsors for tonight's webinar. This is made possible by the Cathay YSS Incorporated Distributors Incorporated. I would like to invite you on our next week webinar series. Titled The Perioperative AKI Prevention, Detection, and Treatment. Speaker is Dr. Michael Walsh of the McMaster University, Canada.